Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP.
And I'm Moz Calafella, also a Melbourne-based GP.
So this will be our third of three podcasts on bone health, and today we're going to talk about treatments. Which treatment, when, and what are the bad things that might happen when we're on these treatments. I'll remind everyone that, of course, as always, the podcast is education and entertainment, hopefully, and can't replace a consultation with your own healthcare professional.
And I think that warning goes double, if not triple, for this week's episode because we're covering quite a bit of juicy stuff, aren't we, Dr. Anne? So there's a lot to cover in the osteoporosis treatment chat. And so I think before we dive into specifics, maybe we'll just talk about generalities so that people can hopefully follow us along in the chat. There's kind of two medication types that we use for osteoporosis, aren't there? And in order to sort of understand them, we sort of want to think about the bones to begin with. Your bones are actually kind of not just random bits of bone that sit in there. They're actually alive, and they are cells, and they've got a blood supply, and they've got all the same stuff as your skin and your heart and your bones. And so essentially they're constantly being renewed. There is stuff that's being produced, there's new bone all the time, and then there's the destruction of that bone over time. And the problem, of course, as we get a little bit older is that destruction, the demolition crew, as you like to call them, they basically start working overtime. They start seeing the light at the end of the tunnel and going, great, let's finish this off. Then work very, very hard. So most of the treatment choices are aimed at either slowing down the demolition crew or asking the bone production crew to make bone a little bit faster, aren't they, Dr. Anne?
That's correct, yeah.
Yeah.
So the ones that target the demolition team, getting them to calm their farm, are technically called anti-resorptives, and that would be things like menopause hormone therapy, previously called HRT, and the bisphosphonates and denosumab. We'll talk in detail about what these things are.
Yeah, don't stress if you don't know the names.
And the other group, the ones that target the bone building crew and ask them really nicely to pick up their game, and they are also called anabolic agents, and they have much less use. They're only used in cases of really severe osteoporosis. The thing is that osteoporosis is, of course, a chronic health condition. Once we've diagnosed it, maybe in your 50s or 60s, we have to manage it for the rest of your life. So we actually often need a 30-year plan. And for a lot of people, you will not be on the one medication for that whole 30 years, that you'll start on something and then maybe move on to something else, which is more appropriate to your age, or if you've had another fracture. So you need to know a little bit about all of the medication options. And in fact, the order that you get them in can be quite important.
Yep, absolutely. So where should we start, Dr. Anne?
I think we'll start with the anabolic agents. As we've said, you often need a 30-year plan, and for some people, they will need these high-powered tell your body to build more bone drugs, but these can only use for a very short period of time, either because they stop working or because it's not safe to use them for longer. So most people will only spend 12 or 18 months of their life on an anabolic agent, and in fact most people won't need one ever. But it's important to get it in the right order. If you are someone who needs a bone builder, you're actually best to get that as your first ever osteoporotic treatment. And the reason for that is that, for reasons we don't understand, getting the bone builder first and following it up with the anti-resorptive gives you much better increases in your bone mineral density than doing it the other way around.
Yeah, that's right. And if we sort of look back to the chat that we had in our last podcast, that's one of the reasons why we talked about needing a bone density scan, even if we've been diagnosed with a minimal trauma fracture and the diagnosis is obvious. Having that bone mineral density scan helps us make that decision around which agent to start first, and if we could benefit from one of these bone builders.
Yeah. So we won't go into the big detail of criteria for being eligible for a bone builder, but if you've had a fracture and you've got severe osteoporosis, a T-score of less than -0.3, then we would be referring you to a specialist to see if you can get one of these bone builders.
What if we don't have a T-score of -3? What are the other options that we can talk about?
Then we will be starting you on one of the anti-resorptives, and for the moment there are three main choices. Yeah. So we've got menopause hormone therapy, which would be only for patients born with a uterus, bisphosphonates, and denosumab. And we will talk through all three options one at a time.
Let's do it.
So shall we start with menopause hormone therapy, the new name for HRT, which isn't yet rolling off my tongue. I don't know about you, Dr. Moz.
No, it doesn't roll off the tongue at all. And not only does it not roll off the tongue, but often I find if I say MHT in a consultation, whoever I'm talking to stares at me with a blank face like I've got three heads. But that's okay. It'll take time.
We'll get there. It's a bit like PAP tests and
Yeah.
CSTs. Yeah, I'm still not getting my head and tongue around those. And I suppose gratifying the patients are generally on the same page as me. They're like, oh.
I've got to be honest, I still say pap test.
Dr.
I've
Moz,
given up on
you're
trying
young.
to call it CST. I recognise that it's not actually a pap test, but still calling it a pap test. I'm sick of the blank stares.
Okay.
Fair enough. So let's
maybe
talk.
we'll allow ourselves to talk HRT this podcast.
Maybe, but remember that it's MHT for scientific accuracy. Yeah.
Yeah. So very conscious that this probably will only be applying to half of our population, but I can't help that. We still have to talk about it. So it's actually the estrogen component of HRT that is effective in helping protect your bones. And fascinatingly, it's probably as good as the other two options, the bisphosphonates and the denosumab, at preventing fractures. So it's weapons grade along with the rest of them. So it is licensed in Australia specifically for the prevention of osteoporosis in postmenopausal women with increased risk of future fractures. I love the addition of the with increased risk of future fracture, because the reality is that if you're postmenopausal women, you have got an increased risk of future fracture. And the new osteoporosis guidelines actually have recognised that, because the guidelines which were issued in 2024 now say that we should be actively considering HRT to reduce the risk of fragility fractures in postmenopausal women within 10 years of their menopause, which is quite a startling recommendation. Yeah.
And it's just like many things in medicine, isn't it, Dr. Anne? Like the pendulum swings one way or another depending on how the information rolls in. So, I think this is really useful information for our patients who sort of were born with a uterus. It is, like you said, there's a weapons grade option that doesn't involve any of the other medications, and will cover all of the bad things that come with the other medications. This is a really good starting point for many people to think about.
Yeah, so the recommendation, if we look at that again, it doesn't say if their T-score is bad, it doesn't say if their FRAC score is bad. It's actually saying that we should be having a conversation with all women in that 10 years post-menopause, discussing the option for them to take MHT, HRT to protect their bones. Doesn't mean they have to take it, but that it should be an option offered to them. Which, if you think back to 20 years ago in the Women's Health Initiative, where everyone's like, dear God, stop your HRT now, you're probably going to die. What a turnaround. Yeah. And
I think, if you haven't listened to the second podcast, it is probably worth having, it's probably worth listening to 1, 2, and 3. But again, coming back to, why bother having this conversation, I think the stat was 1 in 2 women who live beyond the age of 60 will have some sort of, low impact fracture. And so I think it is important to have these conversations.
And again, the recommendation, if you look at the guidelines, says that the increased risk of adverse events associated with treatment should be carefully weighed against the benefits. And there is a lot of concern about HRT that we discuss in every consultation about it. But I guess that the primary concern would be the increased risk of breast cancer.
Mm-hmm. It's an almost weekly conversation, the risk of HRT. I think, Dr. Anne, not specifically breast cancer with every patient, but certainly every week someone is very concerned about the risk of HRT or MHT. And so is there any truth to this? Is there an increased risk in breast cancer? Is every woman with MHT going to suffer a catastrophic breast cancer?
The most reliable evidence we have probably comes from the Women's Health Initiative study, which was a study that reported about 20 years ago and caused the absolute panic about HRT. But nonetheless, if you go back and look at that specific study, it did show that there was an excess risk of breast cancer in women taking combined HRT, so that's both estrogen and progesterone. But the excess risk is less than 0.1% per year.
Yeah. And so that's not saying 0.1% of women will have a breast cancer. That's saying when you compare the group of women that didn't have HRT and the group of women that did have HRT, there is an additional 0.1%. That is a very small number, isn't it, Dr. Anne?
It is. So, looked at another way, if you have 10,000 women between the age of 50 and 79 who are not on combined hormone replacement therapy, 30 of those women every single year in life will develop breast cancer. If you've got 10,000 women of the same age group who are on combined HRT, 38 of them will have breast cancer. So there'll be 8 extra cases for every 10,000 women a year on HRT who will get breast cancer. So the risk is not nothing, but it's less than 1 in 1,000 a year. And that is officially a rare risk. So I think we do need to keep things in perspective.
And so the challenge again is, for those 8 women, they will be significantly impacted. And really, you're not going to know if you're in the 8 because there's going to be 38 women who are going to say, am I the additional 8 and be very regretting of their decision to be on HRT. And I think it's probably also important to again highlight, talk to your own doctor. This is not a replacement for a consultation, but there are some women who, if they have significant increased risk of breast cancer, we may have a conversation with them, but we may not choose to prescribe HRT in those instances. But as long as you are not in a high risk category, the overall excess risk is reasonably small.
Just before we leave HRT, that excess risk is only for women on estrogen and progesterone HRT. For women who have had their uterus removed, they only require to be on estrogen, and there has been no excess risk of breast cancer seen with estrogen-only HRT.
Yeah.
And for absolute completeness, let me say that doesn't mean you should stop taking your progesterone, because the progesterone is there to stop you getting cancer of the lining of the womb if you've still got one. So, dear God, nobody stop the progesterone who should be taking it.
And I think maybe just the other thing as well is breast cancer is a very emotional topic. The minute that you use the word cancer, it's immediately an emotional topic. But I think breast cancer, rightfully so, is a very emotion-inducing disease around the world, but certainly from our experience here in Australia. But I think also, whilst it's not sexy and known about, a neck of femur fracture is very miserable and a really good way to ruin your quality of life and end up significantly impaired for whatever remains of your life. So I think both problems can be an issue, and it's not a competition to say which disease is worse. It's just there are risks on both sides and there are likely benefits on both sides. So it is worth weighing up what the risk looks like for you.
Okay, so we'll move on to the bone-specific therapies. So bisphosphonates is probably the main group of bone-building therapies. They've been around for 40 or more years. You can have them as a weekly tablet, a monthly tablet, or as a yearly infusion. They are licensed both for the treatment of osteoporosis, established osteoporosis, whether that's by your T-score or by having had a fracture. And interestingly, again, according to the new guidelines, also licensed for the treatment of osteopenia, which is reduced bone density, not reaching the criteria for osteoporosis, in women who are more than 10 years post-menopause. They become less popular when the option of denosumab, which is also known as Prolia injections, became available, just because Prolia was so convenient with just a twice yearly injection. We'll talk more about denosumab in a little bit, but for a variety of reasons, denosumab has become, there are concerns over the use of denosumab, and bisphosphonates are now firmly back to being the favoured bone-specific therapy. Yeah. Any problems with bisphosphonates, Moz? Any problems unique to bisphosphonates, actually, is my question.
Yeah, so specific to bisphosphonates, I think probably the main thing that's specific to them is they've got a pretty significant risk of gastrointestinal upset. So we're not talking, a little bit of reflux. We're talking very nasty injury. And so there's specific advice that you'll be given around how to administer it and sitting up for X amount of time afterwards or whatever else. So that's the main thing, I think, with the bisphosphonates. Anything that I've missed?
Obviously, there are two very bad things that happen rarely with both the bisphosphonates and the denosumab, but we're going to cover them together once we've talked separately about denosumab. Yeah, that would be the main thing, that they're a bit of a pain in the bum to take, which is why when the option of denosumab became available, lots of people jumped on it. So denosumab, probably more commonly known as Prolia, it's a twice yearly injection. Yeah, been around for a good number of years.
It was very popular for a period of 5 or 6 years because people were much happier having 2 injections a year rather than taking a weekly tablet that was really annoying to take in terms of administration advice, weren't they, Dr. Anne?
They were loving the convenience of it. And to be fair, I think we were loving the convenience as well. But it's unfortunately fallen a huge fall from favour because of a number of risks which we are about to discuss. Fallen out of favour to the point where I'm very reluctant to start any new patients on it. If I would predict their life expectancy to be more than about 8 years. So yeah, well, I guess it's time to start talking about the bad things that can happen with the bone-specific therapies. Yeah.
So, shall we talk just the denosumab problem first so that we can sort of explain to people why it's falling out of favour?
Yeah.
Yeah. So, of course, we're talking about multiple vertebral fractures. So the vertebra, of course, are the little bones in your spine, the teeny tiny little Lego blocks that make up your spine. And what we found is that essentially if we stop the denosumab or the Prolia on purpose or by accident, there's an increased risk of these vertebral fractures, isn't there, Dr. Anne?
There is. They can be multiple, and the risk is really quite high. To our horror, we find when we've studied it, the risk is 7.5 per 100 patient years. And flipping back to the risk of breast cancer, the excess risk of breast cancer with MHT was 8 per 10,000 patient years. This is 7.5 per 100 patient years. So it's a significant real risk. And it can happen if you're as little as a month late with your injection. So you have an injection twice a year. If life is busy, you go on holiday, it's Christmas, you're looking after the grandkids, whatever. It has been seen as little as 4 weeks late with the injection. So absolute disaster.
And I can't help but think of the hundreds of patients that we see each year where you sort of go, and I'll see you in 3 months for this thing, and then you see them 6 months later, which is fine. Like, that's life. But the problem is that in this context, it has significant consequence, doesn't it?
So 92.5% of patients get away with it, but 7.5% don't.
Yeah.
So if you are a patient on Prolia, it's super, super important that you get your injections on time. And that bad thing will not happen if you do. But we then have issues when at some point we will probably have to move you off the Prolia because there's only safety data for about 8 years. And that will usually involve changing over to one of the bisphosphonates. So I don't start new patients on Prolia now, denosumab, because of this problem. And to be honest, we know that the problem starts after 2 or 3 years of therapy. So if someone's fairly recently started on it in the last year or two, I will have a conversation with them about whether they want to change over to the bisphosphonate just now. And the ability to take a drug holiday on the bisphosphonate is the reason that I get them to do it now rather than after the 8 years. But I'm getting ahead of myself here, Dr. Moz. So
yeah.
We'll stop there on that.
So just for clarity, this multiple vertebral fractures doesn't happen with either menopause hormone treatment or with the bisphosphonates. Is that right?
No, it does not.
Yeah. So just a denosumab problem.
Indeed.
Great. What's the next one on our radar, Dr. Anne? I think it's the atypical femoral fractures.
Yeah. So atypical femoral fractures are a risk with both denosumab, which is the Prolia injection, and all of the bisphosphonates. It's a rare risk. It happens about 1 in 1,000 patient years. And that, again, is officially rare. And it's a stress fracture. It's not your typical fracture that people get with osteoporosis. It's a fracture that develops gradually over time. And it's sometimes called a frozen bone fracture. And if we go back to remembering that these medications are targeting the demolition crew and stopping them doing their work or breaking down the old bone, it can sometimes mean that they can work too well and we're not replacing the damaged bone. So what you would tend to get, the patient often has a period of weeks or months of pain in the thigh or the groin. And if the patient doesn't recognise the significance of that, or the doctor doesn't recognise the significance, that can progress over a period to this peculiar atypical fracture. And it's atypical for a couple of reasons. Typical that occurs a bit lower down the thigh bone than the typical minimal trauma fracture. And it also extends directly across rather than sort of in an oblique pattern. And it tends to start on the lateral side, so the outside of your thigh, and make its way towards the middle. So it is rare. The risk is about 1 in 1,000 patient years. The risk seems to kick in maybe about year 3 or 4, and anyone on denosumab or a bisphosphonate should be alert for increasing mysterious pain in their thigh or their groin, and talk to the doctor about it.
Yeah. So all of those things that you mentioned, and like the the pattern being spiral, all that sort of stuff, that this, it's essentially what we're trying to say is like the mechanism of injury is quite different to, if you fall over and break your hip. And so it's much easier to miss, isn't it?
It is easier to miss because it just presents with some vague pain. And, if you're 60 or 70 or 80, then unfortunately having some pain in some of your joints or bones is kind of life a lot of the time. It's important to say it is a rare risk, and the stats are actually really clear that if you look at the incidence of atypical femoral fractures and the typical ones that you get, you just fall over and break your hip, there are far fewer hip fractures in total in people who are on a specific bone building therapy than people who are not. So overall, your risk of hip fracture is greatly reduced being on your bone building therapy, but your risk specifically of the atypical femoral fracture is increased.
Yep. So we've made the pool of overall fractures smaller, but we've introduced a slightly new version of, or a slightly higher rate of this odd version of fracture into the pool of fractures.
And atypical femoral fractures existed before bone building therapies do, but only 7% of atypical femoral fractures occur in people who are not on one of these treatments. So it does seem to be a curiosity where it kind of you get the frozen bone, the turnover has been slowed so much that you're left with weaker bone and it can fracture. So we will talk about osteonecrosis of the jaw next, I think.
This is this gets a lot of airtime, I feel, when we're talking about these bisphosphonates. It's the thing that we're sort of super scared about, and some people are really aware. But again, it is reasonably rare. So what is osteonecrosis of the jaw? It is basically that the bone in the jaw breaks down because it doesn't have a good blood supply. And so there are a couple of reasons why that might happen. But, essentially with dental treatment or with trauma to the area, we increase that risk that it might happen. And so that's one of the reasons why you'll often hear doctors harping on about, before we get you started on stuff, could you pretty please go and get your dental work done?
Yep, absolutely. It's osteonecrosis of the jaw is greatly feared by dentists more than by patients, I think. And dentists absolutely hate the anti-resorptive therapies. Again, it is a risk both with the denosumab and with the bisphosphonates. So what we seem to need, the prerequisites for osteonecrosis of the jaw, are trauma, which can be often a dental extraction or an implant, infection, and for you to be in one of these medications, and it just seems to be cause a perfect storm in the sauna, where you end up getting exposed bone, gets infected, cuts off its own blood supply, and dies. It is a bit of a disaster. You have pain and swelling, sometimes a discharging hole in your gum, your teeth can get loose, you can lose teeth. So it is an absolute disaster if it happens, but again, it's very rare. It's slightly rarer than the atypical femoral fracture, so the rate's somewhere between 1 in 1,000 and 1 in 10,000.
Have you seen any of these, Dr. N?
I haven't seen it. Have you?
I've seen one, yeah. So I've seen one patient with osteonecrosis of the jaw, presumed to be from bisphosphonates, because, I mean, that's the main reason people get it, I think. But yeah, I've seen one, and it was quite miserable for that patient, I've got to be honest. It was very, very miserable. But it is rare. So I think, between the two of us, we've got several decades of patient interactions, and one between the several decades is not a bad clip. But if you ask that one patient who has osteonecrosis, he will not care how few people we've seen. He will probably think that he's had a pretty miserable hand dealt to him.
Yeah. Well, he would probably not have liked to have a hip fracture either. Not to belittle his distress, but we can never know what would have happened if he didn't take the medication. So attempts to reduce the risk of osteonecrosis, as Moz has mentioned, super important to see a dentist before you start on bone building therapy and get any work done, particularly anything that's going to involve extractions or implants. Once you start on bone building therapies, you really, really have to be very particular about your dental hygiene. If you're somebody, we should all be flossing every day, most of us don't. You're in a bone building therapy, you need to be cleaning your teeth twice a day, you need to be flossing carefully, you need to be thinking about the sugary drinks, because osteonecrosis has become a material risk for you. So both bisphosphonates and denosumab carry the risk. I think more have been reported in bisphosphonates, potentially because there's more people on bisphosphonates for more years because they've been around for 40 years or so, the bisphosphonates. With Prolia, there is the suggestion that if you need to have dental work whilst you're on it, that the best time to have that is about a month before your next injection is due, because your sort of bone levels will be at their lowest at that point. There is no such helpful treatment window with bisphosphonates because they actually hang around in your bone for several years after you stop taking them. But that one advantage to denosumab Prolia, it should not suffice for it to be a great reason to choose Prolia over bisphosphonate.
Yeah.
So the risk of atypical femoral fracture and osteonecrosis of the jaw tend to get higher the more years that you've been on your bone building therapy. And because of that, and because we know that bisphosphonates hang around in the bone for at least 1 year, sometimes 3 years after you stop taking them, the concept of a drug holiday from bisphosphonates came into existence. I feel a wee while ago now. Can you talk a little bit about drug holidays, Moz?
Yeah, so I mean, I think often, so we'll start by saying we don't actually know what the best drug holiday is, but sometimes we'll start thinking about it. Well, actually, some patients will think the best drug holiday is that you never start taking any drugs. But I think considering thinking about a drug holiday after 5 years, so once you've been on it for 5 years, we think it might be time to think about having a little bit of a break. But only if there's been no previous minimal trauma fracture or hip fracture or spine fracture, and your T-score has been reasonably stable for some period of time. How long do they take a drug holiday for, Dr. Anne?
Again, optimal period has not been decided. Anything from 1 to 3 years. You would be having an annual bone density scan over that time. The bisphosphonates are not all the same in terms of how well they're stored in the bone. So actinol hangs around in the bone unless it possibly only hangs around for 1 year, whereas your Fosamax and the infusions, the zoledronic acid, the chemicals in them hang around for longer. So somewhere between 1 and 3 years, being guided by your bone density scan. And why a drug holiday? The drug holiday seems to stop the bisphosphonate building up in your bone, and therefore your risk of atypical femoral fracture and osteonecrosis start falling again, but you're still getting good bone building effect because the bisphosphonates are still in your bone. So it's an elegant idea, but again, we're still at the trying to fine tune exactly when and exactly how long it is safe to do it for.
And that's because it's still a pretty new concept, isn't it, Dr. Anne? And of course, even though we've already said it, this podcast, we'll say it again, not for the people who are on denosumab because of all of the bad things that happen when we accidentally stop. So
definitely not. If you're somebody who's on denosumab injection, please don't think I'll just have a wee holiday from them. You may have multiple vertebral fractures within a couple of months and you'll be hating your life and hopefully not blaming us because we said please don't do it. And nobody should be taking a drug holiday from bisphosphonates without chatting to their usual practitioner about it. It's not that sounds like a great idea, I'm going to do that starting tomorrow. Absolutely not. It's a conversation.
Blame us. Yep. So please go talk to your own doctor. And just for completeness, Dr. Anne, we've talked about these multiple vertebral fractures and atypical femoral fracture and osteonecrosis of the jaw. And we talked about, 3 different types of medications. Can we get all these fractures with menopause hormone treatment or HRT?
No, there's no risk of any of these things with MHT. So it is emerging for those of us who are born with a uterus as probably the leading option, interestingly. And as you know, I was at the International Menopause Congress just towards the end of last year. And the open chat then was that probably for women who have no particular risk factors, it's a therapy that potentially you could take for the rest of your life, But it's a conversation. I'm not telling people to go out and start MHT to take it till they die. I'm saying it's actually a not unreasonable option, but you need to be having a discussion of the individual risk benefit with your own GP. You can also take a bone specific therapy along with your MHT. So if you're on MHT and you develop a fracture, you don't have to stop the MHT to start the bisphosphonate. You can actually take two of them and they work quite well together.
I have to be honest, as someone born without a uterus, I am slightly jealous of the option of being able to take MHT in this specific context, because more and more it's looking like a much more attractive option, and it looks like it's a very effective option.
Fair enough. I have to say that those of us born with a uterus get the hard end of the stick probably.
That's why I tried to make it very specific. Definitely.
In terms of options for bone health, we sort of are winning at the moment, no argument. Yeah. Of course, flip side of that is that our risk of a minimal trauma fracture for those born with a uterus is substantially greater than those born without. So maybe there's some balance there.
Maybe there's some balance. And of course, if we've got to the point where we're talking about medications, does that mean we can just go ahead and ignore all the things that you and I talked about in podcast 1 and podcast 2 around lifestyle and diet?
Oh, no. These things are really, really important. And you've got to be calcium replete, getting enough vitamin D, getting enough protein, and doing the exercise. You will recall we needed purposeful stomping 4 or 5 times a week. We needed resistance training, I think, twice a week. And we did challenging balancing training at least twice a week. And no smoking and moderate alcohol. We have to be doing these things or we're too to be wasting our time with the medication.
Very good. Excellent. Anything else you want to cover with the treatments, Dr. Anne? I think we've definitely spent a lot of time, a lot longer than we anticipated we would.
Indeed, yeah, and people might have to listen to it in 2 halves. Yeah, so highlights would be that unfortunately denosumab is no longer terribly well favoured. Probably worth a chat to your doctor about what the long-term plan for that will be if denosumab is your current treatment regime.
Very good. Excellent.
Everything was. Thank you for your patience and your help.
Thank you. If you've made it this far into the podcast, we appreciate it. If you haven't had a chance to listen to episodes 1 and 2 around bone health, please do give them a listen. We think that they make a really valuable addition to your sort of information around your understanding of bone health. Remember to give the podcast a like, Apple, Spotify, YouTube. Share the podcast with your friends or anyone that you think might benefit from the information that we've shared today. And follow us on the socials. Go give the Facebook and the Instagram a bit of a like and see what's going on over there. Dr. Anne, thank you very much for your time.
And for yours. See you next time. Bye.
See you next time. Ciao.